So we're continuing with some more abdominal CT cases today. There is a bit of a theme to a few of them, and there's some teaching points that we'll discuss. So the first case is an 80-year-old female, and this is the history that we've been provided. So she had a sudden onset of abdominal pain, unwell on arrival to hospital, hypertensive tachycardic with diffuse abdominal tenderness. So they decided to do a CT, but because of acute kidney impairment, they wanted it without intravenous contrast. So have we got a volunteer to do this one?
So we have non-contrast CTs. I'm looking at the axial slices to begin with. And in the central abdomen, there are some dilated loops of small bowel. Going further down, some of the dilated loops appear to have slightly hyperdense attenuation to the bowel wall, which is slightly concerning. The mesentery associated with these dilated loops are wet, they're stranded. So I would be concerned about ischemia of this bowel wall. The pattern is more in fitting with a venous etiology because of the wet mesentery. The hyperdense wall is probably representative of some hemorrhage in the mucosal wall. So if there was contrast available, I'd be looking for SMB thrombosis and things like that. So in summary, I think this patient has bowel ischemia of the small bowel.
Okay. And is there, what could you, I know we don't have contrast on this CT, but what could you look at with regards to the vessels to give you some idea as to whether or not there might be a venous thrombosis? Is there anything at all?
So I could look for, if there was a clot that could appear hyperdense.
Yeah.
And there could be stranding around the vessels.
Yeah, I think it's tricky. So we know that in other parts, for example, if you're looking at the femoral vessels on a CT, and you see that one of them unilaterally is hyperexpanded and the content is hyperdense and there's some fat stranding around it, that would be strongly suggestive of deep venous thrombosis. I think it's slightly trickier though with mesenteric vessels and particularly the portal vein to make that call.
Yeah.
But yes, with regards to the other findings, so the main pattern really, and I'll go to the coronal views, which I think really help, is that there is dilatation of several loops of small bowel, some of which are gas-filled, some of which are fluid-filled. There's this really wet-looking mesentery. The small bowel looks congested, edematous, the density's increased. And then, as you picked up, it's difficult, but if you look for it, it's often seen. There's hyperdensity of the bowel wall in many different locations. So, for example, here I would say that this wall is more dense than we would normally appreciate with the small bowel. And that's important to pick up in this particular kind of CT. So before we even started with that history that's been provided, one of the things at the top of your differentials that you're looking for is this a case of mesenteric or bowel ischemia? And if you are forced to do the scan without contrast due to many different reasons, patients allergic to contrast or you can't get IV access, there is still value in doing the CT. And what you're looking for is exactly this. Is there any abnormal distension of the small bowel? Is there any abnormal density in the small bowel mesentery, which is suggestive of an acute process? And is there any hyperdensity in the bowel wall? And as you said, that hyperdensity represents mural hemorrhage. And mural hemorrhage is one of the events that happens in the cascade of events that's occurring in the bowel wall along the ischemic pathway. So on non-contrast studies, look for hyperdensity of the bowel wall, which is a sign of mural hemorrhage. Now, ideally, what you'd have is a contrast study, and that would give you some further information about the vessels, as you've said. But with contrast, what you see is obscuration of the innate density of the bowel wall without contrast. So this is where dual energy CT has been really played up as a very important tool in looking at bowel ischemia, because you can generate a virtual non-contrast image that will tell you what the actual density of the bowel wall is. And then with the contrast on top, you can actually assess what the enhancement is, what the additional increase in density is with the contrast. And so that is said to increase the confidence of readers in detecting bowel ischemia. Now, let's move on to second case. So, this second case that we're going to look at is a 75-year-old female. She has come in with a similar history to the first case: sudden onset abdominal pain, hypotensive and tachycardic. She has a history of smoking and hypertension. So they wondered whether or not, in fact, she had ruptured abdominal aortic aneurysm, because that would all add up to someone who's a vascular path, sudden onset abdominal catastrophe. So she's having a CT. So I want you to talk me through, first of all, what kind of phases you've got here. And also, is there anything in the ideal world that you'd have added here, and why? And then also just talk me through your findings as well, please.
So we've got arterial and portal venous phase CTs. So from the history, we probably also want a pre or non-contrast scan. The reason for that would be to see whether, if there's a dissection, for example, whether you'd be able to see hyperdensity within the wall of the aorta.
Okay.
So looking first at the arterial phase scan, just going from top to bottom, we can see the heart's enlarged. There's a small bilateral perfusion and a bit of atelectasis in the right base. There's also some contrast in the hepatic veins. This patient's probably got a bit of heart failure. Moving down, we can see there are quite a lot of dilated loops of mainly small bowel throughout the entire abdomen. They're not, the bowel wall's not particularly thickened, but it does appear to be a bit hypo-enhancing. It's difficult to see whether there's a lot of edema in the mesentery. You can't really see it that clearly, but I'd be worried about ischemia. So following the vessels down, if I look at the SMA, we can see that it abruptly comes to a stop. Probably clearer on the sagittal view. So we go to sagittal, then you can see it quite clearly. It just comes to an abrupt, at least the contrast comes to an abrupt stop halfway down. So it looks like there's an SMA occlusion, which would explain the findings we've seen. And then other things, so there's just gallstones.
Okay.
Yeah, I think that's about it.
Okay, yeah, so I agree. This is a case of an arterial small bowel ischemia. So we'll work our way through this. So as you said, first of all, with that history where they're thinking about an acute vascular problem, we should consider doing a non-contrast phase. And as you said, looking for intramural hematoma, and also sometimes you have situations where actually the abdominal aorta looks plumb normal on the non-contrast study. So it's not aneurysmal, there's no hyperdensity in the wall, there's no periaortic hemorrhage, no recuperational hemorrhage. And in fact, the patient's acute abdominal presentation is due to something completely different. Like, for example, a very severe case of pyelonephritis or diverticulitis, and in which case a portovenous study would be sufficient once the non-contrast has been reviewed. Now, in this particular case, we've got an arterial and venous phase, and the main abnormality with regards to the bowel is distension of much of the small bowel. with fluid and gas within the lumen, and as you said, very poor enhancement to the bowel wall in many different places. When you've got a venous phase, always compare the enhancement in the venous phase as well, because you may be caught out on the arterial phase. You may overcall hypo-enhancement. So look on the venous phase, and I would agree that even on the venous phase, there are many places in which the enhancement to the bowel wall is suboptimal. And then the other finding with regards to the bowel wall is that the bowel wall is quite thin. Now, classically, if you look at the literature, the arterial small bowel ischemia is described to have a paper-thin bowel wall. So this is a thin bowel wall. And then we look at the vessels, and then, as you described, there is an abrupt cut-off a few centimeters from the origin of the SMA where there is no flow of contrast. Okay. Just as a follow-up question, so this is an SMA obstruction, supramesenteric artery obstruction causing arterial ischemia. What's the commonest cause of this type of obstruction? What's the etiology? Is it embolic or in situ thrombosis? Does anyone know?
Embolic, maybe?
Yeah, that's right. So 50% of cases are said to be due to embolus from a central source, such as, for example, atrial fibrillation or plaque shearing off from the aorta. And then a smaller proportion are due to in situ thrombosis, maybe 30%. And then further lower down the list, things like dissection. So you can get dissection, perhaps extending from the abdominal aorta or into that SMA, and then that's a cause of reduced flow as well. Okay, but so yeah, this is a sort of example of a textbook, if you like, example. They're not always like this, of clot in the SMA. So reduced flow. You got poor enhancement of the small bowel. It's paper thin and it's distended. Right, let's move on to case 3. This is a 70-year-old man who's presented with colicky, low abdominal pain and vomiting, tachycardic with diffuse abdominal tenderness with a raised white cell count. So
Okay,
why don't
so
you...
this is a portovenous scan of the abdomen and pelvis. There is a frank non-occlusive thrombus seen at the main portal vein that extends to the main branches. It extends down to the SMV, which causes total occlusion of the SMV and the branches of the SMV as well, draining the small bowel. There is a loop of small bowel, particularly the jejunum, which shows a mural thickening and submucosal edema with surrounding of the adjacent mesentery. I'm looking for the cause of this portal vein thrombus, which could be some inflammation inside the abdomen, which I cannot appreciate. I mean, there are some diverticuli in the sigmoid, but there are no signs of inflammation, no appendicitis. So overall features are consistent with SMV portal vein thrombosis with small bowel venous infarction, and this is an emergency and need to be communicated to the referring physician for urgent surgical opinion.
Yeah. Okay, so let's just work our way through that. So as you said, there's from the top, there's ascites, there's fluid here around the liver and the spleen. And then it becomes fairly clear very soon that there is a non-occlusive filling defect within portal vein, so left and right main portal vein branches, so main portal vein, and then extending down to the superior mesenteric vein and many of the tributaries of the superior mesenteric vein. And here it looks like it's more filling the lumen of the vessel, so it looks more occlusive. So acute mesentero-portal venous thrombosis. And then the consequence of that is this effect on the small bowel with quite a long length of small bowel, but particularly the proximal small bowel involved by the process. And the signs that we see specifically are, we see thickening of the wall to a much greater diameter than we normally see. And then in many places, we see this target-like pattern. So we have this mucosal hyperenhancement, then submucosal hypodensity, and then the outer layer is hyperdense. So you get this target-like pattern of 3 different density layers. Again, congestion and free fluid within the small bowel mesentery, a few small inflammatory looking nodes. The distal small bowel looks okay. Now, whenever we see this, we've got to think, well, why is there a thrombosis? And usually with mesenteric and portal venous thrombosis, we look for a distal source as a starting point. So acute diverticular disease, sometimes maybe appendicitis is uncommon. But if you can get spontaneous formation of venous thrombosis, which can lead to this. And then the treatment for this would be anticoagulation to get rid of that clot, and then hopefully, and keeping a close clinical eye on the patient to make sure that this doesn't progress to infarction and then necrosis, whereas this may well be recoverable ischemia. And in fact, I don't have the follow-up for this patient, but I know that follow-up study 4 weeks later, because they stayed well, they were anticoagulated, and the small bowel recovered to normal, and the clot began to retract within the portal and mesenteric veins. But the target sign is a very important sign to look for with venous small bowel ischemia. Case 4 is a 65-year-old woman who's had several weeks now of increasing abdominal pain, but much worse than the last few days, and that's triggered her admission to hospital. She's tender all over with raised inflammatory markers. So do you want to talk us through this one?
Yeah. So these are CT abdomen images of an adult patient which has been acquired in the portovenous phase. The most obvious abnormality is the dilated small bowel loops, which are seen in the right lower quadrant, which are not enhancing. There's associated mesenteric fat stranding, and there is a soft tissue mass lesion in the mesentery adjacent to these bowel loops, with an associated desmoplastic kind of reaction. There are few foci of calcification within these lesions, and the SMV and the SMA appear to be engulfed by this lesion. There's some fluid in the abdomen, and the liver, I'm not able to see any focal lesions. So features are in keeping with mesenteric ischemia, bowel ischemia due to mesenteric mass, likely a carcinoid with involvement of both the artery, SMA artery, and the vein. And yeah,
Okay.
I'm not able to see.
All right. So what would you recommend next in terms of further investigations?
Patient needs to be urgently seen by the surgical team in terms of patient management. In terms of further investigation, because this is a neuroendocrine tumor, further nuclear medicine studies could be done.
Yeah.
Octreotide scan is the next step for evaluation of carcinoids.
Okay. Anything else? More immediate? So just thinking about what we've done here. So you've made a pickup of a mesenteric neuroendocrine mass, which is likely to be a carcinoid type of tumor.
Yeah.
And then we've got the consequences of the bowel changes. But if this is a carcinoid, it's a malignant lesion, isn't it?
Yeah.
So
we need a staging. Yeah.
Yeah. So what would you do with regards to that? How would you do that?
So we would do a CT chest as well to finish the staging of the tumor.
What kind of phase?
An arterial phase chest.
Okay, and including the chest and
the proximal part, the upper abdomen till till the pelvis, yeah. Till above the
Okay.
pelvis.
Okay, yeah, so let's just talk through that. So yes, so from the beginning, from the very top of the portal venous, we see that there is free fluid around the liver. And then as you scroll down, as you said, there is a lot of abnormal small bowel, particularly within the right lower quadrant. And there is this mass within the mesentery. So let's just look at that mass first of all. So it's irregular in outline. It's got several foci of clustered calcification within it. It looks otherwise hyperdense. And then the coronal views are very helpful in showing that the superior mesenteric artery and vein run right into the center of this lesion. And then all of this mesentery around it looks like it's just puckered and drawn in towards this lesion. And all the small bowel that's supplied by that particular mesentery, part of the mesentery, is abnormal. Okay? And the abnormality is this really marked thickening of the small bowel, but with low density of the bowel wall. So everywhere you look, the density is quite low, but it's very, very thickened. And then there's really marked congestion of that small bowel mesentery. So this is absolutely typical for a mesenteric carcinoid tumor. This is what it does. So it wraps in the vessels into it, and then there's this combined arterial and venous ischemia of the associated small bowel. So whatever length of small bowel is being supplied by that portion of the mesentery will undergo this process of chronic arterial and mixed venous ischemia, and then eventually will reach a trigger point which makes this patient attend hospital. And look for those little foci of calcification, this irregularity. Now, a couple of extra things you should do is remember that this is not the primary tumor, this is the secondary deposit. So look carefully at the small bowel loops nearby to see if you can spot the primary itself. Here in this case, I couldn't really see it very clearly, but what you'll often find is this tiny hyperenhancing nodule in the small bowel, and that's what's causing this. And then don't forget that this is a very vascular lesion, and the metastases from this lesion to the liver will also be hypervascular, and they may well be obscured on a portal venous phase study of the liver. So you really need an arterial phase study of the liver to clearly see metastases from neuroendocrine tumors. So when you're doing the chest CT, you should just do an arterial phase. You should do that in the arterial phase and extend to involve the liver as well. And then, of course, in due course, you'll be doing all the neuroendocrine studies to work up this tumor in greater detail. Okay? So let's just go through a few different aspects of bowel ischemia. So if you look at the literature, you'll find that when they talk about enhancement of the bowel in ischemia, you'll find talking about absent enhancement, or it may be just diminished, it may be led, it may be increased. So it's quite confusing to think, well, what's actually going on? The thickness of the wall can actually be very thin, paper thin, like that case we saw, or it can be thickened. And the bowel is usually dilated, but it may not necessarily be dilated. So it's very tricky sometimes to understand, well, how can I hang this all together into a logical pattern? And I think one thing that helps is if you think about bowel ischemia as not just one entity, but essentially a number of different entities depending on the specific cause of the ischemia. So at one end of the spectrum is the arterial type, which we saw, that first case, the second case. And then venous ischemia, the other end, which was that third case that we looked at. And then mixed is just like the mesenteric carcinoid I showed you, when there's a bit of arterial, a bit of venous. And then there's also this entity known as NOMI, non-occlusive mesenteric ischemia, also known as shock bowel. This is when you have reduction in intestinal blood flow due to other conditions, and which leads to the bowel temporarily looking very abnormal, but it's a recoverable state. So if we look at the characteristics of bowel wall thickness, enhancement, the vessels and the mesentery, this table shows you what I think are the most typical findings. Now, with all of these, don't forget that there is variability. So typically in arterial ischemia, the bowel wall is paper thin with reduced enhancement. But depending on the phase of the disease, you may well see some bowel wall thickening, and you may well see subtle hyperenhancement, but this is a typical finding. With venous ischemia, we saw that you get that thickened bowel wall with engorgement of the vessels, that target sign, and it's typically a wet type of ischemia, whereas arterial ischemia is generally quite dry until late. So in that case we saw, it was difficult to appreciate the mesentery, but there wasn't much fluid when we did look at it. With mixed ischemia, then you can get a combination of different patterns of findings depending on which is predominating, arterial or venous. Case 5 is a 25-year-old male with an acutely painful swelling in his right groin. So suspicious for an incarcerated inguinal hernia. They want a CT just to confirm if that's the case. So why don't you talk us through what you've seen?
So start by looking at the axial slices. So we've got portovenous phase scan in which there is extensive inflammatory fat surrounding within a right inguinal hernia, in which it looks like there's part of the appendix going in there, which is quite inflamed as well and hyperenhancing.
Okay.
So appearances are in keeping with an strangulated inguinal hernia containing the appendix. I know it's got an eponymous name. It's escaped me right now.
Okay, so yeah, I think on this case what we see is that there's definitely abnormality in the right groin. So there's bump in the skin contour, this swelling that we see, and that's because of increased volume of tissue within the right inguinal canal here. So there's a lot of fat here, and that fat's got an increased density. It's inflamed, and there's also a small volume of free fluid here. And then posteriorly, there's a structure, tubular-like structure, which we appreciate better on the coronal view. And if we follow that, that's heading straight into the abdominal cavity, and you can run it all the way to the cecal pole. So that's the appendix. So the appendix is here within the inguinal canal, and it looks slightly thickened and slightly inflamed, and the fat is inflamed as well, and there's some free fluid. And this has got a particular name to it. So does anyone know what this is known as?
Amyot hernia?
Yeah, that's right. Yeah. This is what this is. So this type of hernia is essentially appendix, which is inflamed. So acute appendicitis, and then within an inguinal hernia. Okay, so it's an inguinal hernia with appendicitis. So described by this guy, Claudius Amyot, 17th century French surgeon, and he performed the first recorded appendicectomy in 1735, and this type of hernia is named after him. This is case number 6. So this is an 80-year-old woman who's got sudden onset right groin pain and swelling with raised inflammatory markers. So you see there's another bit of a theme developing here, right? So why don't you talk us through what you see on this CT?
Okay, so again, this is a portovenous face CT. Most obvious abnormality I can find is within the pelvis, where once again there's a right-sided inguinal hernia with increase in the volume of soft tissue in the region. There's also some fat stranding and free fluid within the hernial sac. Just tracing it more proximally, I've suggestion there's possibly a segment of the bowel entering the hernial neck. Just looking at the coronal to see where that's coming from exactly. Not entirely convinced, but it could be another segment of the appendix, possibly just the tip, but not exactly convinced. But I feel like I can trace it proximally on the coronals. More proximally on the CT, there's a large calcified gallstone, but can't see any other obvious abnormality. A little bit uncomplicated diverticulosis of the sigmoid.
Yeah.
No pneumoperitoneum or free fluid within the pelvis itself.
Okay.
And no upstream bowel obstruction that I can see.
Okay. So what's your kind of conclusion?
Well, I was thinking, I don't know, it's unlikely to be the same case again, but I was thinking whether this is another sort of appendicitis secondary to an amnion hernia, but not entirely convinced by if I can actually trace that appendix all the way to the cecum.
Okay. So, all right, let's just deal with that bit first. So I agree with you that down here, within this bulbous bit of tissue, there is centrally within that something which looks like a tubular structure. And if we follow that back up, then I think that this is joining up with this here, which is the appendix. Okay, so I agree with you. I think this is appendix. I can't think of what other kind of tubular structure this would be. And it does join up, so I think that's the appendix. So the next question is, what kind of hernia is this?
So again, it doesn't have the entirety of the appendix in it, so I'm not sure if it'd still be classified as an amnion hernia.
Okay, thinking about rather than how much of the appendix is in there.
Yeah.
Thinking about what kind of groin hernia is this?
Okay, fine. So looking at the relationship with the femoral vessels, it seems to be rising medial to the femoral vein.
Yeah.
So it could be part of the femoral canal. So there's a possibility this could be a femoral hernia.
Yeah. So it can be tricky on CT and MRI to actually differentiate inguinal from femoral hernias. Now, what I look at here is this looks very close to the medial aspect of the femoral vessels, and the femoral vein on this side is slightly narrower compared to the left side, suggested as mass effect. And then if you look at the coronal images, you can see that this is not really in a direction going down the inguinal ligament towards the labia, right? This is more vertically oriented. So this is in fact a femoral hernia containing the appendix. Okay, so this is quite rare because femoral hernias by themselves are quite rare. And then to have acute appendicitis within a femoral hernia with acute inflammation all happening is quite rare as well. Does anyone know what the name of this type of hernia is? So this is not the same as the previous one. This is not an omniont. This is something else. Does anyone know? No? Okay. So this was named after another type of surgeon from back in the day who has a fantastic name, René Jacques Croissant de Garangeau. And he first described this in 1731. So acute appendicitis within a femoral hernia. So the next one, number 7. This is a 55-year-old male who's come in with lower abdominal pain on the right side with nausea. He's got this history of previous inguinal hernia repair on the right side and hypospadias. And when they're examining, there's a palpable swelling in the right groin, which is not reducible, which is very tender. But the testicular exam is normal. So the CTs look for a possible recurrence of an inguinal hernia on the right side, and which is acute in nature. So with inflammation.
Sure. So I've started looking at it, and it's a CT abdomen and pelvis in a portal venous phase. Just scrolling down into it, you mentioned the right groin, and in that area, you can see fat stranding as a tubular structure enters into the kind of inguinal canal, not inguinal canal, sorry. Into the groin, basically. Enhancing. nothing else in particular that sticks out. It doesn't appear to be bowel that's going in. Don't think. Let me just look in the other view.
Okay.
So I'm just looking in the coronal as well.
Yeah.
Can't tell anything in particular. I'm just going to look in the sagittal quickly.
Sure. Okay, what do you reckon?
I'm just going to track this back up.
Mm-hmm. Okay, so
1 second.
Yeah.
Yeah, I'm not sure.
Okay. All right. So I think this is a tricky one. Before I say what it is, does anyone want to? I'm just going to mute you. Does anyone know what this is? Okay. So we've had 2 cases of right groin swelling. Right. One was appendix in an inguinal hernia. One was appendix in a femoral hernia, and both of them presented with acute new painful right groin swelling. Okay, and this is a third case in acute painful right groin swelling, except this person has had previous repair of an inguinal hernia, so slightly unusual. And again, what we see is an asymmetric pattern of change. The left side looks relatively normal. The right side is swelling and there's inflammation, so there's increased density of the fat, so the fat stranding that we talk about. And that fat stranding comes up along the path of the right inguinal canal. But there's no tubular structure within this one similar to the other one that we follow back to the bowel. So there's no appendix that we can follow from here down into the inguinal canal. There is a tubular structure here, but that's not the appendix itself. Okay, so this is not the appendix, this thing here at the tip of the arrow, that's not the appendix. Now the remarkable thing here is, if we follow this, there's also this abnormal enhancement here on the right side, which is again asymmetric. The fat in the right side of the pelvis has a generally increased density compared to the left side, you see here. And then look at this again, we're now at the level of the top of the seminal vesicles, there's thickening here of the structures, and increased fat stranding compared to the left side. And then in the seminal vesicle itself, there's this focus of hypodensity, which we don't see on the left side. So this is an acute inflammatory process involving the vas deferens and the spermatic cord within the inguinal canal, presenting with this acute swelling and enlargement. So this is known as vasitis, which essentially implies inflammation of the vas deferens and the spermatic cord. So we don't see this very commonly, but they do present as causes of right groin swelling. So it's an acute infection, and the pathogens involved are the same ones that are involved in urinary infections. It's a mimic of an acute inguinal hernia, similar to those other 2 cases, which one was an inguinal hernia but with appendix in it, and one was a femoral hernia. Look for hyperenhancement. So on CT, look for hyperenhancement of the vas deferens and the spermatic cord. You'll find this asymmetric appearance, and you can follow it all the way back into the pelvis, and you see it's thickened on one side, enhancement's greater. Look for an associated seminal vesicle abscess, and I think on this case, those hypodensities within the seminal vesicles could represent small abscesses. Case number 8. 25-year-old female with sudden onset of abdominal pain. So I think there's a couple of different investigations. So what do you see on this chest x-ray first?
So we've got a PHS x-ray and it shows obvious pneumoperitoneum. The lungs are otherwise clear.
Okay. Anything else? Just pneumoperitoneum, right?
Just pneumoperitoneum.
Okay, and then the next thing she had is a CT, abdomen pelvis. So why don't you talk us through what you see here?
So as we scroll through the CT, we can see that there's pneumoperitoneum mostly in the upper abdomen.
Yeah.
And we can see, I think there's some in the stomach wall as well.
Okay.
The rest of the abdomen looks okay, and with the amount of air collected in the upper abdomen and around the stomach, I would go for a differential of this being a sort of upper GI perforation.
Yeah. What do you think the specific site of the perforation is?
They're likely to be at a common area would be the duodenum.
Yeah. Yeah, that is a common site. What do you think about the stomach here?
It's distended with a lot of matter and gas within the wall.
Yeah. So it's a very abnormal stomach. It's very distended. I think this looks like it's gas within the wall, but I suspect it's trapped just deep to the wall.
Mm-hmm.
It is inflamed. I think the cause of the perforation here is stomach wall ulceration, and it's the stomach that's perforated. And as you said, there's a very large pneumoperitoneum, so all of this is free gas within the abdomen. Does anyone know what's going on in the stomach here?
Bezoar?
Yeah, what type of bezoar?
Hair.
Yeah, that's right, yeah. So this is a...
Rapunzel.
Yeah, sorry, say that again.
Is that Rapunzel syndrome?
Yeah, that's right. So this is Rapunzel syndrome, or a trichobezoar, okay? So all of this material that you see here, all of this is not food, this is actually hair. So this is just a very large hairball within the stomach. You can see here, okay? It's causing inflammation of the stomach, which has caused the stomach to perforate, and then she's presented with that pneumoperitoneum that you saw on the chest x-ray and on this abdominal CT with a very large volume of air. Just another thing here to look for is look at this fat down here, okay? So this is a typical appearance of very inflamed intra-abdominal fat. It looks much greater in density than the surrounding here retroperitoneal fat. Okay, so that's a very good thing to look for, that kind of feature of fat inflammation. So this is one of the many different types of bezoars that you can get in the abdomen. Trichobezoar, which is hair. You can get phytobezoars, which are basically stones from different kinds of fruits, like apricot stones that people have ingested. They can cause things such as obstruction, similar to gallstone ileus, but caused by a stone. Okay, so this is a trichobezoar. 20-year-old female who has consumed an entire pizza the previous night. She's come in with abdominal pain with a raised lactate. And the abdominal x-ray she had, which we haven't got here, suggested she has some pneumatosis. So can you scroll? I've handed the control to you. Can you scroll? Yeah?
Am I doing it?
Yeah, you
Yep.
are. I can
Okay.
see. I can see that. Yeah, go on.
Right. From the very top,
Yeah.
there's a axial CT portovenous phase. I see a very distended esophagus coming right, and then there's pleural effusion coming down, very distended stomach, air within the liver, I want to say, is extending to the periphery. So I'm guessing that's portovenous gas.
Yeah.
Stomach very distended. I would normally window it a bit better and see whether this is free intraperitoneal gas, but it seems to be following the contour of the stomach.
Yeah.
The stomach is very, very distended. Coming down further.
So I think the coronal views are quite helpful here if you want to switch to those. Yeah.
Let's try that. Yeah, does not seem to be free intraperitoneal gas, but this is a grossly distended stomach.
Yeah.
You can see this bit of a wall is enhancing, and then I lose the enhancement going around it.
So that gas within the liver, where do you think that is? We have two main places really we see gas within the liver, don't we? So it's either biliary or
either
portovenous.
in the portovenous systems or in the biliary tree.
Mm-hmm.
So to decide whether it is portovenous or biliary, from memory, I believe portovenous is more periphery, and in the biliary system, it will be more central.
That's right, yeah. So,
and I can also look at the comment about that, whether that's got air within that. It doesn't look like it, and the presentation doesn't suggest biliary problem. That's why I'm gonna bet on portovenous gas.
Yeah. Okay. Great. Thank you.
Thank you.
Okay. Let me talk through this. So basically, we had the history of this consumption of entire pizza the night before. So this is a case of gastric ischemia. Okay, so here as we scroll this, as you said, there is gas within the stomach wall. I know we haven't got the lung windows, but it's following the contour. So this is gastric pneumatosis. The coronal view shows you how grossly distended the stomach is, with very poor enhancement of the much of the stomach wall, apart from here towards the pylorus. And we see that gas within a very large portion of the wall of the stomach. And then you also point out there's gas within the periphery of the liver. So this is within the portal venous system, not within the biliary system. So the stomach is actually quite resilient and does not undergo ischemia very easily because there's such a rich blood supply from many different routes into the stomach. However, when it becomes very, very grossly acutely distended, the stretching of the stomach wall can lead to ischemia, as has happened in this case. It becomes atonic. It's not able to get rid of the food into the small bowel. And as a result of that stretching and poor flow into the stomach wall, you can get ischemia, necrosis of the mucosa, gas translocation into the wall of the stomach, and then that then very easily escapes into the portal venous system and into the liver, as you see here. But this is relatively uncommon because the stomach is more resilient than the small bowel and the large bowel to episodes of ischemia, which we don't see this as much as we see small bowel or large bowel ischemia.